Good morning to everybody. So I'm here to talk about, the medical management of peripheral arterial disease. These are my disclosures. So the first thing you have to understand is peripheral arterial disease, or lower extremity arterial disease for this purpose, is the most malignant form of atherosclerosis there is. If you have peripheral arterial disease, at least 2 out of 3 are going to have significant coronary or cerebrovascular disease. And if you actually further look, probably 80 to 90% of them have some amount of disease. Okay. The second thing you've got to understand is most people with peripheral arterial disease are not going to die from an acute leg attack. They're going to die from an acute heart attack or a stroke. So when you have an individual with that, you have to be sure that you're actually managing that also. In other words, taking care of the risk factors from that perspective. So what I'm going to do is I'm going to try to show a few things. One is managing the limb outcomes. I'm talking about medical management of it. And also how to address the cardiovascular morbidity and mortality, and perhaps kind of show you where we are despite our recognition of this at this point in time. So with the limb outcomes, clearly the main thing is, improving walking time, claudication time. Again, we're not referring to critical limb ischemia where obviously it becomes surgical. That's the most pressing need, revascularization. But in people with just claudication, what are things that you should be doing and you should be looking at? So if you look at limb outcomes itself, the main thing, obviously, the cornerstone is exercise. There is a guideline document that came out in 2011, and since then hasn't been a great number of updates, but I'll try to highlight the few studies that have been looked at as far as that goes. So the first thing is, as all of you practice and know, is a supervised exercise program has the highest recommendations and strength. The key word here is supervised exercise program. Okay? A supervised exercise program has a class 1A indication, and we'll go over how to do this, but essentially it's 30 to 45-minute periods at least 3 times a week, preferably closer to 5 times a week. Now, if you look at actually unsupervised exercise programs, in other words, you're telling your patient, go home, walk it till you get pain, stop, and then restart. This is what all of us do, but that does not have the same amount or level of evidence. This may be because your patients don't understand us as to what to do. This may be because the patients don't follow through on what to do, compliance perspective and all of that. But generally, that hasn't shown as much success as, say, you would have with a supervised program.
It's like buying a gym membership. It doesn't have much.
Exactly, to do with that, exactly. That's a good analogy there. So if you look at actual exercise training and effect on claudication, consistently, you look at meta-analysis, consistently what you see is an improvement in onset of claudication time and also the maximal claudication pain. Both of them are improved by your exercise therapy. Clearly, there's no doubt about that. So what would a program look like? So now here, recently they actually did even a study where they randomized individuals, as you can see here, with aortoiliac peripheral arterial disease. They randomized them to stenting, as you know, that would be a class 1 indication right there, or exercise therapy, or optimal medical therapy. It wasn't a huge number of people, as you would see here. About 119 individuals randomized, 40, and about 20 over here. But what they found in the study was that exercise programs, the supervised exercise programs, had an improvement in walking time even compared to stenting. Okay? Now you can argue about what the quality of stenting was and things like that. Those would be difficult for us to judge over here, but it suggests that exercise is an important and a key part of it. So in other words, in your individuals with peripheral arterial disease who come for claudication, this should be your first step, trying to see if they're able to improve their walking time and all of that. And that's when you kind of start figuring out if lifestyle limiting claudication requires further stenting and so on. Optimal medical therapy did the worst of the 3, so clearly exercise program becomes important and a cornerstone. So what should one look like? It's 3 to 5 sessions per week, as we talked about, 35 to 50 minutes. You can do treadmill, track walking, and so what have you. But essentially, what you advise your patient is to start walking. You push them till they start getting about a moderate amount of claudication pain, then stop. Then rest till the pain goes away, and then restart and go through the cycle over and over again. A typical training prescription would look something like this. You have a warm-up phase, you exercise, rest, and what you'll see is over time this exercise period becomes longer and longer till they get claudication, and that is your endpoint of what you want to achieve with this. As far as medications themselves go for improving claudication, there are 2 drugs that are approved by the FDA. There's Pentoxifylline and Cilostazol. Both of them are FDA approved for improving claudication pain. Now, pentoxifyline's been around for about 30 years right now. The dose is 400 milligrams 3 times a day. It's a hemorrheological agent. In other words, it's supposed to help with the red cell shape and things like that. It helps you with flow and hence with your symptoms. Now, on the other hand, cilostazol is a phosphodiesterase inhibitor. It's been there about 15, 16 years. The dose here, as you can see, is 100 milligrams 2 times a day. Now, with cilostazol, the one major thing that you want to be careful about is in individuals with heart failure. Any systolic dysfunction, anytime you have an EF that's low, you do not want to use cilostazol because it can exacerbate that. Now, what is the efficacy of the two? You can see pentoxifylline versus placebo. I don't see a major difference, but it was, I guess, statistically significant enough to get an approval. But you can see clearly with cilostazol, you do improve your walking time. So to me, if you're using a medication in setting for improving claudication, cilostazol probably is your go-to drug. But be careful with the caveat about the heart failure individuals, so you would not use them in that. So that was that. Now, then moving on, we talk about, for the sake of time, I'm moving on. This is just the strength of evidence over here. You can see pentoxifylline only has a class 2B. So moving on as far as the actual management of the cardiovascular risk factors themselves go, smoking cessation therapy is clearly a key cornerstone. This is associated with improvement both in your claudication time and also cardiovascular morbidity and mortality. Now, normally, we're used to telling people, oh, you shouldn't smoke, and letting it go at that. Now, if you look at actually quality metrics they're starting to judge you on, they actually ask you, they have you go through a certain, few parameters. In other words, each visit, you're supposed to ask your patient, are they ready to quit? And people who are ready to quit, you have to give them the tools, the encouragement, and things like that. People who have actually quit, you want to encourage them, on their congratulate them on their quitting smoking, and kind of help them to stay away from smokes. So these are part of your physician performance evaluation that's being incorporated by different hospitals and things like that in these days. So just saying yes, no, is he a smoker or not, is she a smoker or not, is not sufficient anymore. But what are the steps you're taking also becomes important from that. But essentially, there are, it's one of the still the more difficult things to take care of, trying to get somebody to quit smoking. It's obviously an addiction. It's a very difficult thing to do. But this is something that we should be focusing on. Now, if you look at the guidelines themselves, you would see that, these are kind of the things that we talked about. Every visit, we should ask them about smoking cessation, and we should assist them with smoking cessation itself. Individuals with lower extremity who use tobacco or other forms should be at every visit, counseled on quitting smoking. Now, is there data saying that smoking cessation helps? And this is one of the studies. There are several studies like this, but this is an Australian study where you can look at what the outcomes of individuals who don't smoke. There's a general census. People who quit smoking or tobacco abstinence and continued tobacco smoking. And clearly you see that over time, post-operative, after you had, in this situation, bypass graft or a lumbar sympathectomy, you have persistent effect of that. And if you quit smoking, you start seeing a benefit with that. So there is evidence to say that even here the outcomes are improved. And clearly there's cardiovascular benefit for quitting smoking itself. Now, the next thing that we focus on is moving on to lipid-lowering therapy. Now, this is a cornerstone of preventing your heart attacks and strokes. Previously, until about a year and a half or so ago, your goals used to be an LDL cholesterol less than 100 and high-risk individuals less than 70. Recently, there have been a new lipid guidelines where they made it a point to include peripheral arterial disease in the family of the atherosclerotic cardiovascular disease. In individuals with peripheral arterial disease or any kind of atherosclerotic cardiovascular disease, your goal is to get them on a high-intensity or a moderate-intensity statin therapy. Now, what is high-intensity statin therapy? Currently, there are a couple of drugs which can meet that standard. It's Atorvastatin 40 to 80 milligrams, or Rosuvastatin 20 to 40 milligrams. The lower doses of these and some of the other ones, like simvastatin, would be considered moderate-intensity statin therapy. The key thing in this, the newer lipid guidelines, was it does not matter what your LDL cholesterol is when you start. Your LDL cholesterol is not what is important. It's the percentage reduction you have, because none of the studies, clinical studies that use statins, ever included people based on an LDL cholesterol number. They just qualified because they had heart disease, and nowhere was they pushed to targets of less than 100 or less than 70 or what have you. What they do is just randomize individuals to high or low intensity statin therapy. So this has been a sea change. This happened about 2013 in the overall cholesterol guidelines. I'm sure everything is going to catch up, but essentially this is what is the key thing for you to remember. In individuals greater than 21 years of age who are a candidate candidate for statin therapy. The age is less than 75, you would do high-intensity statin therapy, and moderate if they're not able to tolerate it. Age greater than 75, because that's where your statin side effects go up, among other things like kidney disease and liver disease. In them, you would consider moderate intensity statin therapy. One question that gets asked is, what if the LDL cholesterol is too low? We still don't know what is too low, but generally what the guidelines say is if your LDL cholesterol is less than 40 on a couple of visits, then you can back off or cut down on the dose of your statin. But remember, even if you start at an LDL cholesterol of 85 or 90, okay, high-intensity statin therapy is going to give you 50% reduction. It's not going to get you to less than 40. So it's very difficult to push people to less than 40. So that's something, so you don't have fear using this medication. And this is one of your, life-saving medications, if you would, among what we have at this point in time. What is the evidence? If you look at several of these studies which have looked at statins, consistent benefit among peripheral arterial disease, and more so, even for claudication time, there have been studies that have looked at it, and here you can see Atorvastatin 10, 80, or placebo, and both the 10 and 80 seems to improve the claudication time, or the time for onset of claudication. Here you see 10 did a little bit better. I wonder why later on it kind of evens out, but maybe the 80 had a slightly higher statin-mediated side effect of muscle pain, and so individuals didn't push themselves as much. So in your individual with muscle pain, you may have to rethink how intensive you want to get that. But in general, the high-intensity statin therapy will help you with both, both your claudication time and in reducing your cardiovascular events. Other than that, antihypertensive therapy, you would follow guidelines. The guidelines have slightly changed recently again in this, but in general, the main thing is your goal is 140 over 90 is a easy number to remember. There used to be a stricter guidelines for diabetics and kidney disease. They found that if you target lower blood pressures, you tend to have more side effects and individuals don't tolerate them. So they don't ask you to push it that low any longer, but if you are doing well at a lower blood pressure, it's fine to continue your medication. Another common misconception that used to be was use of beta blockers in people with peripheral arterial disease, that it may be contraindicated. Several studies have looked at that, and people tolerate that just fine. So there is no contraindication to using beta blockers in the setting of peripheral arterial disease. One other question that's asked is, if you lower your blood pressure, after all, perfusion is, the problem in your peripheral arterial disease, can you worsen claudication? Typically, they found as long as you don't lower your blood, you have to lower your blood pressure 20 millimeters of mercury or more to start impacting claudication a little bit. And most of your individuals, you don't have that much to lower, and you should do okay with that. So ACE inhibitors, again, you would use it in people with established cardiovascular disease. It's reasonable. These are just the classes of recommendations and kind of what we've covered as in the last few seconds. And for the sake of time, I'm going to move on with these. And this is the newer guideline wherein they relax the blood pressure recommendations more, especially in older individuals where they say even up to 150 over 90 is okay. You don't have to treat unless it's above 150 over 90. Now, the last two things we have to look at is in your diabetic patient, do not forget foot care. Remember, the ulcer in a patient with diabetes is the start of the whole process, which leads them finally to the amputation. So foot care has to be emphasized. So if you're practicing as a vascular surgeon and you send your recommendations to your internist, be sure to include that saying, please make sure the patient gets adequate foot care, and advise on that also. As far as the antiplatelet recommendations themselves go, aspirin is good enough, 75 to 162 milligrams. Clopidogrel is a good alternative. In specific individuals, adding aspirin to clopidogrel can have some benefit. So in your higher risk individual, adding both of them can have some benefit. But in fact, most of the studies actually show that clopidogrel may be slightly better than aspirin as far as the outcomes themselves go. But because, from the cardiac standpoint of view, there seems to be no difference, aspirin still holds the stronger recommendation. But in your select individuals, you can combine the two, or if you're not able to tolerate aspirin, clopidogrel is a good alternative for them. And the next few slides just give you the strength of recommendations for that. And these are the studies which show that clopidogrel actually was overall favored compared to aspirin in specific subgroups of patients with PAD. Now, overall, what have we been doing with this? Overall, peripheral arterial disease continues to be an undertreated entity. People do not recognize it. Perhaps it's lost between internists, vascular surgeons, cardiologists as to who has the ownership of the patient for the medical management of it. Maybe the internists think they've referred them to vascular surgeons, so they're taking care of it, and vice versa. So essentially, several data, and even more recent data than what we have here, have consistently shown that people in general either are not aware of their diagnosis, or if they're aware of their diagnosis, you can look at what percentage of people had lipid-lowering therapy. Almost controls had the same number of people with lipid-lowering therapy and antiplatelet, despite this being the most malignant form of atherosclerosis. So we have to do a better job from a medical management, because I again tell you that people are going to die from heart attacks and strokes, and very rarely from a leg attack. So performance measures are coming up, and you will be, as practicing physicians taking care of this, you will be asked to, held to these standards. So know these. These include the things that we talked about, including smoking, who's on statin, who's on blood pressure targets and controls. With that, I just acknowledge people who've, contributed this, and I will stop there. Thank you.